Hello, I'm Adrian Gowdy, and in this lecture we're going to talk about the use of ultrasound to diagnose various parenchymal lung diseases. Now this is an area that is often thought of as very new, but in actual fact, if you look back at the history, this was being explored many decades ago. For example, this was from a paper published in 1967, which looked into the investigation of patients with suspected pulmonary emboli. And I don't want to go into detail about the paper, but I do think it's worthwhile just looking at the conclusions that the authors made. They said that ultrasound for the early diagnosis of PE had a number of advantages. It was simple enough to be done by an intelligent technician with a minimal amount of training. It was rapid, could be done at the bedside. Positive diagnoses were made in the presence of completely negative chest x-rays. Small emboli, at least in terms of projection of underlying areas of ischemia on the chest wall, could be diagnosed. And it was safe because it did not involve the injection of radioactive or radiopaque material. And now, after a period of really dormancy for a number of decades where people wrote off ultrasound from the investigation of lung disease, we're suddenly seeing a lot of new interest, and a lot of the benefits that were pointed out in this paper 40 years ago we are now recognising are just as true today. And so this is an area that is currently undergoing rapid development, and as such the nomenclature can be variable. We are exploring the limits of its utility, and really of all the areas of lung ultrasound, parenchymal disease really is at the cutting edge. And as such, not everything is known, and some of the things we say in this lecture may well change in the future. But nevertheless, what we can say at the moment is that it looks very, very promising. And almost certainly it has a very big future in the emergency department and in the care of critically ill patients in general. So what are the things that we look for when we're considering whether or not there is parenchymal lung disease present? Well, these are the signs that we're going to go through, and then we're going to talk about the pathology and which of those signs link to various pathologies. We're going to look at lung sliding, we're going to look at the lung pulse, we're going to look at lung comets and rockets or beelines. The pleural surface gives a lot of information, and we can also look for pleural effusions. So let's go through them one by one. Okay, lung sliding is just the same as when you're looking for pneumothorax, and that will have been discussed in detail in the pneumothorax lecture. But one of the things that it's very important to remember is that not all loss of sliding is due to a pneumothorax, and that in many parenchymal lung diseases there will be either a reduction or sometimes a complete loss of lung sliding, and we can use that to help distinguish between some of these disorders, as we'll talk about later. The lung pulse, in many ways, that is equivalent to lung sliding. Lung sliding is where you see the lung movement due to respiration. Lung pulse is where there is movement between the parietal and visceral pleura due to transmitted pulsation from the heart and the great vessels in the mediastinum. In terms of interpretation, it really means the same thing as lung sliding, in that its presence excludes a pneumothorax at that point. So let's have a look at what that actually looks like. Now this is a video from a patient who's got pulmonary fibrosis, so it's quite easy to see his pleural surface, and we'll talk about some of these other changes in a moment. We can see the heart beating here, and there is some lung sliding with respiration, but in addition to that sliding, you can see there's pulsations in time with the heartbeat. And as I said, in terms of interpretation, whether there is movement due to lung pulse or whether there is movement due to lung sliding really means the same thing. So moving on, one of the most important artifacts that we look for when talking about parenchymal lung disease are what are called lung rockets or beelines. As I said, the terminology is a little bit variable. Personally, I like the term lung rockets because I think it's more descriptive. Some people actually refer to these as lung comets, but I don't think that's a good term because as well as these comet type artifacts, which are abnormal, you can also get very small little comet tail artifacts at the pleural surface that are completely normal. And so if you use the term lung comets, it's hard to know which one you're talking about. These are a reverberation artifact. Very importantly, they extend from the pleural surface to the edge of the screen. They cut across A lines and all other lung artifacts. And if there's lots of them, they can actually become confluent to give a white lung area. So what do they look like? Well, here's the pleural surface, and here we have these reverberation artifacts. They look like torch beams. They're sometimes described as those. In some ways, they sort of make me think of 70s disco strobe lightings moving back and forth across the screen. So they're usually very easy to see, and they move with the pleural surface because they arise from the pleural surface. Now, the presence of these B-lines or lung rockets has led to the term the alveolar interstitial syndrome, and that is defined as being the presence of more than 3 lung rockets per area examined. Now, they're not particularly specific for any given disease because they occur in a range of diseases. They occur in pulmonary edema, they occur in ARDS, they occur in diffuse parenchymal lung diseases, pulmonary fibrosis, etc., and in pulmonary contusions. The presence of rockets on lung ultrasound has been correlated with CT changes, and it's been found that rockets that are 7 millimeters apart correspond to interstitial thickening seen on CT. More closely spaced rockets, those that are less than 3 millimeters apart, correspond to a ground glass appearance, which is due to alveolar fluid. Now, in normal people, you may see 1 or 2 rockets at the lung bases, especially in people who are a little older. In addition, the lung fissures will usually give you the appearance of a lung rocket, and that will occur, first of all, in the expected anatomical position, and you can often track these down between the rib spaces to show that they are actually the fissure, and in addition there is only the single rocket at that point. So let's have a look at some examples of this. This is from a lady who is 45 years old, and she was diagnosed as having pneumonia. She had no history of heart disease. And when we ultrasounded her, this is from the left chest, we see there's lots of these white lines moving back and forward, as I said, a little bit like strobe lighting, floating backwards and forwards across the dance floor. And what we see here is the surface here, the pleural line, is smooth. And bear that in mind when we look at some of these other examples. There is lung sliding. It's very easy to see when there's lots of rockets. And when you're looking at rockets with pulmonary edema, their distribution, as you would expect, tends to follow gravity because it's due to interstitial edema. So the dependent areas tend to be worse. In addition, it has been shown that if you look at dialysis patients and you look at their lung rockets pre-dialysis, as they are dialysed and as the fluid is taken off them, the number of lung rockets actually decreases, corresponding to the reduction in their extravascular volume. If we look at pulmonary fibrosis, and this is from a chap who's had asbestos exposure, we see again lots of lung rockets here. They become confluent in areas. But if we look at the pleural surface here, it's irregular. So that's one of the differences between pulmonary fibrosis and pulmonary edema. Again, we can see lung sliding, although it may be reduced in pulmonary fibrosis depending on the severity. Now here, this is from a patient who was shown to have interstitial pneumonitis. This was a young lady who had previously had endocarditis and had severe tricuspid regurgitation and right heart failure with that. Presented and was profoundly hypoxic. And when we did her lung ultrasound, what we showed was, again, lots of lung rockets through here, an irregular surface, but the presence of lung sliding. Now, she actually went on to have a CTPA because her degree of hypoxia was so profound. And what we can see here is diffuse groundglass opacity all the way through. She had this patchy groundglass distribution throughout her lungs, and she was diagnosed as influenza pneumonitis. And so, as we've mentioned in those cases, when we're trying to interpret the lung rockets, we need to look not just for the lung rockets, and the number will help give us a bit of an indication to the severity, but we need to look at the pleural surface. Is it smooth or is it irregular? Is there sliding? Is it normal or reduced? And what about the distribution? Is it in gravity-dependent areas or otherwise? And in pulmonary edema, we expect to see a smooth pleural surface with normal sliding and gravity-dependent distribution. Now, sometimes people have said that you can occasionally get an irregular pleural surface, but I don't know if that's from the pulmonary edema, or rather is it pulmonary edema in a patient who's previously had some parenchymal scarring or so forth. In ARDS, there is an irregular thickened pleural surface. There is reduced sliding. Importantly, compared to pulmonary edema, it's a patchy distribution in that you will get normal or spared areas between the areas where you see lung rockets, as opposed to pulmonary edema, which will generally get worse as you go into the more dependent areas. And the patient who's sitting upright, the apices may well be clear, but there'll be lots in the bases. As well, in ARDS, you get anterior subpleural consolidation. And we'll show you some examples of consolidation in a moment. And in ARDS, over time, you get this progression from a normal lung to multiple rockets, which then coalesce until you get large white areas, and then you get frank consolidation. In pulmonary fibrosis and interstitial pneumonitis, there is an irregular fragmented pleural surface. There is usually reduced sliding, and the distribution will depend on the cause. Some forms of pulmonary fibrosis tend to predominate in the upper lobes, some in the lower lobes, and you'll see this based on where the rockets are. Now, the changes in pneumonia do depend on how dense the consolidation is that you're looking for. In dense consolidation, so on a plain chest x-ray where you'd see a white area, then you'll see what's called hepatization. And it's called that because the lung really does look like liver. You can see air bronchograms. Sometimes you can see fluid bronchograms, particularly in a post-stenotic pneumonia. And there is usually reduction and sometimes complete loss of lung sliding, which you can imagine if a whole lobe is densely consolidated, well, it's not going to move much, it's too heavy. So this is the sort of thing you'll see. And as I said, at first look, this looks very, very similar to liver. But first of all, I can guarantee that this was not liver because this was high up on the right chest. And when we slid down, we saw the liver as a separate structure. These bright areas here represent the air bronchograms. And so you need to be able to identify small areas of air. Get used to what that looks like on ultrasound, as we mentioned in the artefacts lecture. This was a patient with dialysis who presented with septicemia. And when we looked at the chest x-ray, you can see this whole dense lobar consolidation. So it's not surprising that we can see that on ultrasound. So in dense consolidation, we see the area that looks like liver, but with bronchograms in it. But much more commonly than seeing patients with dense consolidation, we see patients with patchy infiltration. And in those cases, what we'll tend to see is an irregular pleural line. We'll see small hypoechoic areas with irregular edges. And within those areas, there's usually small bronchograms. They can be air bronchograms usually, occasionally fluid bronchograms. You'll get reduced lung sliding. Around that area of the consolidation, there will be inflammation, and with the inflammation will become interstitial fluid, and so you'll see rockets around those areas of consolidation. And usually you'll have some pleural fluid and a small pleural effusion. So here's an example of, this is taken from the left chest. You see a rib shadow here, a rib shadow here, and here in between, here's the pleural surface. So this is where we expect the pleural surface to be. But here we have this sort of triangular area. It's an irregular border. In fact, it's abnormal down here as well. And we get these little bright dots, and these are the little air bronchograms. So this is a little area of consolidation. Now this has been looked at. There's a small number of studies at the moment. There's currently a number of studies going on, and these are being released. The ones that have come out so far tend to be fairly small, but as time goes on, we are seeing more studies of increasing quality. And so far, they all seem to be pointing to the fact that ultrasound has a sensitivity of around about 90%, but a very good specificity around about 98%. And bearing in mind that plain chest x-rays will tend to miss about 15% of pneumonia. Ultrasound, although it may not be as good as CT, seems to be probably better than chest x-ray. So this is the sort of thing. Here is a patient. This was an 87-year-old gentleman who was actually meant to get on a plane to fly back to Europe that afternoon. He was feeling lethargic. His chest x-ray shows some patchy infiltrates all the way through. We didn't have any old chest x-rays because he was a tourist. In his lung ultrasound, when we looked at the upper chest, that all looked quite normal. There's a little bit of lung sliding there. When we looked at the lower chest on the left-hand side, here we see a small pleural effusion. Here is the edge of the lung coming in. This is the diaphragm here. And when we went across through his chest in the left posterior chest, what we saw was this irregular area here with a little air bronchogram sitting in them in this wedge shape here. So this is a classic picture of a patch of pneumonia. Now sometimes as well you can see the complications of lung infections. Here we see dense hepatization, so dense consolidation, but in the middle of that dense consolidation is this anechoic area here. And this is a lung abscess. This was actually due to cryptococcal pneumonia with a lung abscess. Here is the plain chest x-ray from that patient. And there's maybe a little suggestion in here of an abscess, but certainly we thought that it showed much more clearly on the ultrasound. Ultrasound has been used in the investigation of pulmonary embolus, and there are changes that have been described. You get multiple hypoechoic triangular or round defects. These are well demarcated from normal lung, and this is a bit different to the pneumonias. In pneumonia, you get the surrounding inflammation, and so you get rockets around the edge of the abnormality, whereas in pulmonary emboli, they tend to have very sharp, distinct borders, and you'll have normal lung movement. Now these pictures are taken from Professor Mattis's paper. And here we see this as an example. Sharp edges here and a slightly rounder appearance here. Now, the diagnosis of PE is based upon the number and distribution of these lesions. And if you have a number of these lesions throughout different vascular areas, then that's highly probable. If you have a single one, well then it's low probability. And this sort of gives me flashbacks to the old nuclear medicine reports of intermediate probability, and well, we still really don't know. From a personal perspective, my experience with PEs and ultrasound is small, so I don't know how good this is. But compared to the other pathologies that we're talking about today, where we get definite signs and definite changes on ultrasound, to me, PE is still going to remain a diagnosis that is going to be based predominantly from an imaging perspective on CTPA. Now, to mention COPD, there actually aren't any particular lung ultrasound features of COPD. And so in many ways, this is a diagnosis of exclusion. You have a patient who is breathless, and yet the lung ultrasound seems to be normal, then you have to start thinking of COPD, particularly in the appropriate clinical setting. Just remember though, when the lungs are very hyperinflated, the amount of movement is going to be small because they're not shifting that much air. Similarly, if you have a bullous, the amount of movement with that at the pleural surface is going to be reduced. And as a result, sometimes it can be very hard to decide whether or not there is actually lung sliding there. And this is one of those reasons that we mentioned earlier on with lung sliding, that don't forget, loss of lung sliding does not diagnose pneumothorax. The presence of sliding excludes a pneumothorax, but its absence, pneumothorax is one of the causes, but there are other causes, including COPD and bullae. So, what are the limitations of this technique? Well, as I said, it is new, and we're still exploring this and looking into them. The specificity and sensitivity of these abnormalities is not yet well defined. We also know that there's overlap between the findings, for example, between pulmonary fibrosis and pulmonary edema. So how useful is ultrasound in distinguishing between them? For example, in the patient who you know has pulmonary edema, who you know has pulmonary fibrosis, but you want to know, do they have pulmonary edema on top of that? And that's something which I think is going to be very challenging for all imaging modalities, because they will just show the changes that are there. And in many ways, I think it is going to have to come back to the clinical picture to work out which is a predominant or whether there's mixed disease. Having said which, there is, certainly in our own personal experience, we've had a growing number of cases where we've thought clinically that there is going to be one main disease process, and then we've either found a different disease process due to a different diagnosis, or often that we are finding two different disease processes in the one patient, and it's making us think that there are other things going on as well. The example I showed earlier of the pulmonary edema in the lady who we thought had pneumonia, she did have pneumonia, but associated with the pneumonia and the severe septicemia that she had with that, she got depressed cardiac contractility and had heart failure as well. And in fact, her clinical course turned the corner once she was diuresed, she deteriorated, she got intubated, ventilated, and on the third day, the chest x-ray reports, interestingly, on the first day said pneumonia, the second day said pneumonia with maybe a bit of heart failure, the third day they said, yeah, we think there is some heart failure here. She got diuresed, and within 12 hours of being diuresed, she was extubated, sitting up, and was transferred to the ward. And so those are the kind of cases where I think ultrasound is showing that although it may not clearly differentiate between one disease and another, it can certainly help raise the possibility of alternative or coexistent diseases that can significantly alter management. So in conclusion, I would say that lung ultrasound can differentiate between different groups of lung pathologies. It may not necessarily give you a definite diagnosis, and you are still going to have to interpret the information in the clinical setting to give you the best, most likely diagnosis at that point. And that the benefits of ultrasound, its portability, its rapidity, its repeatability, make it an ideal modality for the critically unwell. And that includes in a general sense, but also specifically in the diagnosis and management of lung disease. Thank you.